Okay, so let's go a little bit behind. So today, this is our discussion points. Next, two common types of headache, primary and secondary. Primary, that the primary pathology is the headache is the disease. Next is the secondary, when it is due to some other disorders. Then we have discussed the pain generators that is written in this slide. Next, we have discussed the classification of the ICHD3 classification, among which first three are most important: migraine, tension type headache, and the trigeminal autonomic cephalalgias. Then we have the other types of headaches that is listed here. And next we have come to the migraine. So in migraine, we have already told that there are two types of migraine, very common. One is the common migraine, that is the migraine without aura, and migraine with aura, or the classic migraine. Now, depending on the episodic or chronic, when it is lasting less than 15 days a month, it is usually comes in episodes. It is known as the episodic migraine. When it is occurs more than 15 days a month, then it is known as the chronic migraine. Then migraine complications, probable migraine, and the episodic syndrome that may be associated with migraine. So as I have told previously, that sometimes it is very difficult to differentiate these conditions. That means patients is coming with some features of tension type headache, some features of migraine, and some features of other headache disorders. So this is common, and here we need to find out which is most probable. That is why these last two terms are there. Okay, there is probable migraine and episodic syndromes that may be associated with migraine. Now coming to the tension type of headache, this is the commonest type of headache. Remember, migraine is the commonest type of headache that requires hospital care, or patient comes to the hospital because of the headache, that is the migraine. And the most common type of headache that doesn't requires always a medical attention, that is the tension type of headache. And tension type of headache again classified in various groups, among which few are infrequent episodic tension type headache, frequent episodic tension type headache, chronic tension type headache, probable tension type headache. So here in all the classification, you will be finding this type of non-specific diagnosis is put together. Now coming to the third group, as I have told, they share a common basic point. That means they are associated with the unilateral autonomic symptoms. That means either there will be lacrimation, or there is redness, or there is congestion, or there is nasal stiffness to one side of the face. That is quite common. Among those, the commonest group is the cluster headache, which is more common in males. Next is the paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attack, or that is also known as the shunt syndrome, hemicrania continua, probable trigeminal autonomic cephalalgia. So these are the classifications. They are actually 1, 2, 3, 4. They are grouped together into this broad group of trigeminal autonomic cephalalgias. And these are the other primary headache disorders. In the group 4, I have not explained there because there are a long list. So like primary cough headache, primary exercise headache, primary headache associated with the sexual activity, cold stimulus headache, external pressure headache, primary stabbing headache, pneumolar headache, hypnic headache, new daily persistent headache. So all these grouped together under this other primary headache disorders, or in the group 4. Okay, and this first four consist of these types, among which most of the headaches are self-explanatory, except this primary thunderclasp headache. Remember, this is usually associated with the subarachnoid hemorrhage, but it usually, these terms should not be taken into account here. Okay, in those cases, you should be thinking these conditions as a serious condition. You should not be diagnosing this diagnosis on the first go. And pneumolar headache, the term is actually localized neuralgia, where there is coin-shaped area in the head that is painful. So these are the other type of headaches. Now coming to the red flags. This slide is very, very important. Remember, all sudden onset headaches are red flags. That means in those cases, if it is a recently developed headache, then you should take the maximum care and you should consider it a red flag sign. Next is the worsening pattern of the headache. And always remember, sometimes that might happen that the patient is having some chronic headache, because this chronic headache is quite chronic, like migraine. Okay, the patient suffers for years. So if there is any change in nature, character of headache, okay, or intensity or frequency of the headache, that should be considered again as a serious type of headache. And in those cases, you should reinvestigate and get the case. That means you should not miss any important clues here. So sudden onset headache, worsening pattern of the headache, neurologic symptoms and signs like altered mental status, weakness, diplopia, papilledema, focal neurologic deficits, all considered as a red flag for the headache. Patient with immunosuppression or cancer, if they developed headache, that should also be considered as a serious form of headache and should be taken carefully. Meninges mass, obviously, it should be taken as a red flag. Onset of headache over the age of 50, that is also considered a red flag. That is headache in aged thunderclasp headache, severe thunderclasp peaks within few seconds. That is also a very severe type of headache and it should be considered a red flags. Symptoms of giant cell arteritis like visual disturbance, jaw claudication, fever, weight loss, temporal arterial tenderness, paroxysmal myalgias, this also be considered as a serious headache or red flag sign. Okay, systemic symptoms like fever, weight loss, if they are present, that again should be considered as the red flag. Progressively worsening headache is also a red flag. Red eye and the halos around the light, it is also considered as a dangerous type of headache, and these are all red flags. In those cases, you cannot wait. You need to go for the investigations and take care immediately. So in the headache diagnosis, this part is very, very important. Now, what are the possibilities in those conditions? Okay. Red flag, we are considering new headache after the age of 50. So what are the possible causes? Like temporal arteritis, a brain mass, a giant cell arteritis. Okay, in those cases, we should consider ESR, that's inflammatory markers basically, and diagnostic test for the temporal arteritis and the neuroimaging. These are very much important. Now, very sudden onset headache or thunderclasp type of headache is considered possible causes the brain bleed. That's why in the other headache group, there was also a primary thunderclasp headache, which is not due to these conditions. But I have said that this type of diagnosis should not be done unless and until these things are proved negative. Okay, so brain bleed, vascular malformation, and this is the congenital vascular malformation being undiagnosed for a quite long time. It is quite common. Okay, and it is, I have seen at least 2 persons in my very, very close relatives, they have lost their lives because of this condition. Okay, so initially there was headache for 7 days, 10 days, but as it was a new onset headache, but that was missed, and that was initially thought it is a minor headache, so they can paracetamol, and ultimately they have succumbed to the injury. Okay, so remember, in those conditions you should take care and you first go for the neuroimaging, and if the infection is considered, you should go for the lumbar puncture. That is also may be done if the CT is negative. Okay, but some cases we consider MRI as well. Okay, especially in the posterior fossa, we should consider the MRI as well. Now, headache increasing in frequency and severity, we should consider mass, subdural hematomas, medication overuse, and we have to go for the neuroimaging or we need to go for the drug screen. New onset headache in the person with the possible HIV or cancer, definitely the patient is immunosuppressed, so we should consider the infections like meningitis, brain abscess, etc. And we should go for the neuroimaging and lumbar puncture if neuroimaging is negative. Now, headache with the signs of the total body illness like fever, stiff neck, rash. Again, these are signs of the infections like meningitis, encephalitis, collagen vascular disorders. Okay. Again, we need to go for the neuroimaging, lumbar puncture, or serology. Okay. So papilledema, you all know, it may be a result of the brain mass or where the intracranial hypertension is there, meningitis, encephalitis. So again, we need a imaging and required, if required, lumbar puncture. Next, severe headache following head trauma. Again, you should consider the brain bleed, post-traumatic headache. So again you need to go for the neuroimaging. Okay, inability to move the limbs. Okay, here we could consider the arteriovenous malformation, collagen vascular disease, intracranial mass lesion. Again we need to go for the neuroimaging and the blood test for the other disorders. Change in the personality, consciousness, mental status, central nervous system infection, intracranial bleed, mass, they are the suspicions. Again, we need to go for the blood test, lambda marcher or imaging. Metabolic disorders, we need to go for the blood test, and toxic ingestion like carbon monoxide, drug overuse, then we need to go for the blood levels. So the importance of these 3 slides is that you should not miss a single case of headache that is attributed by these disorders, okay, which are dangerous and that can threaten the patient's life. So what you need to evaluate? In history, you need to evaluate when it started, the age of onset, okay, then location, it is primary unilateral or it is bilateral or it is global, okay, pain intensity, progression, okay, how it is progressing. Every type of headache having its own pattern. Okay, sometimes the patterns are overlapping. I am telling this again and again because what happens, even for me, when I got headache and ultimately when gone to the see the patients, the dilemma was always there with me, that is this a migraine or some features of tension type of headache is there. Okay, usually the symptoms are mixed, so we need to differentiate on the basis of history only. Okay, here nothing is going to much help, and you should make you try to your points and make your diagnosis. Definitely here it is better to write a provisional diagnosis and a differential diagnosis as well. Okay, if you are thinking it is most probable migraine, but it may be a case of tension type of headache, that is my second possibility. So put it in the differential diagnosis, and if required, always write 2-3 differential diagnosis as well. Then with the investigations and with the drugs as well. Okay, whether it is the responding with the specific medication or not, in that way you can find out which type of headache the patient is suffering from. Okay. Next, come to the progression, how it is progressed, how long it is staying, how much frequent are the attacks, okay, then character of the headache, duration, frequency of attack, what are the aggravating or relieving factors, okay. So sometimes happens that if it is a migraine patient, so what happens, the patient prefers that he should stay in a cold calm room or a dark room. It doesn't like light as well, okay. There is associated nausea, vomiting, these features are there. So by those you need to differentiate. Okay, and aggravating factors, you all know about the migraine triggers, like going to the sun, like taking some specific foods, or having empty stomach for a prolonged duration of time, or a late night, or a flashes of light. So these are the common migraine triggers. So we need to find out that aggravating and relieving factors, whether they are present or not. Next, we need to find out the associated features like aura symptoms. Okay, so if the patient is having an aura, okay, visual aura or auditory aura, or visual, especially the visual aura is the most common, that is the fortification, or even the motor auras are also there, okay, in hemiplegic migraine. Okay, so we need to find out these conditions. Okay, so aura symptoms, whether they are present or not. Next is the premonitory symptoms, whether they are present or not. Sometimes in migraine, premonitory symptoms may be present, but not the aura symptoms. That also happens. Then there might be a scrotoma, okay, skin plating scrotoma. One side you cannot see, okay. So I have a video also. One of my patients just told me, मैं सांस को देख रही हूँ, but I can see only one side of her face, not the other side. Then impact on daily activity. Okay, that is also important. Like if the patient is suffering from the tension type of headache, then the impact of on daily activity is least. That means with the headache, patient can continue his daily activities. So in those cases, you should not consider him as a migraine. But whereas in case of migraine, the daily activity is hampered. In cluster also, daily activity is severely hampered. Next, migraine, sometimes we get the family history. We need to get the past history, like cluster headache that might be clusters in past. In mid-time, there might be a symptom-free period. So past history is also very important. Past history of head injury or any other disorders is also very important. Whether the patient is taking any specific medicine for that or not, that should be taken into consideration, and we should consider the comorbidity as well. So it is a big thing that needs to be diagnosed. So for an headache diagnosis, you should at least give 30 minutes time to the patient to for all these questions to ask, and then you need to make your diagnosis. Now coming to the physical examination. Remember, in primary headache disorders, in physical examination, you may not find any a single thing. Okay, all the physical examination, whatever you do, is maybe absolutely normal. So we need to go for a general survey. Then we need to go for a systemic examination, especially on the cranial nerve, central nervous system, especially the cranial nerves actually. Then we need to examine for the heart function, inspect, palpate, and the cranial nerve examination the in detail needs to be done. Next, we need to find out the mental status of the patient, neck rigidity, face symmetry, trigger points, tenderness. We need to check the temporomandibular joint as well, whether there is tenderness over the temporomandibular joint or not. We need to check for the cervical spine as well, because we all know there is another term that is known as the cervicogenic headache, where like occipital neuralgia. Okay, here the problem is at the neck, but the pain is coming at the back of the head. That is also a possibility. So we need to find out those associated points in case of these headache disorders. So that much we need to examine. Now, this is the thing what we need to test for the cranial nerve. In short, okay, you can check everything, but as we are doing it from our undergraduate dates, so I am not going to discuss it in detail. Now coming to the investigations. Okay, remember, investigations in primary headache actually gives no feature practically. So blood test in primary headache disorders like migraine, cluster headache, all are normal. Plain X-ray again normal, CT scan again normal, MRI angiography. These are the tests that is required on the specific conditions. Okay, like when in case of we have to suggest that the patient is not improving, or the red flag signs are present, CT scan is commonly done. If we need to evaluate the posterior part, we need to go for the MRI as well. Then we need to go for the MR angiography if we are thinking of any vascular malformations, or in case of trigeminal neuralgia, we commonly go for the MRI or MR angiography, especially with the trigeminal neuralgia protocol, to see whether any aberrant blood vessel is there or not. Okay, then we need to do the diagnostic blocks as when required. Okay, so what are the diagnostic interventions we need to do in case of headache? So occipital neuralgia, we go for the occipital nerve blocks. In our advanced course, we show the technique of occipital nerve block under ultrasound. It is at the cervical region. So as a basic course participant, you should not be doing it initially, but definitely when your expertise increases, you can go at the level of the lamina of the C2 and over the inferior oblique muscle, you can block this occipital nerve as well. Okay, to check whether the greater occipital nerve only, so whether their pain is due to occipital neuralgia or not. Next, trigeminal neuralgia, that is another disorder, a very painful disorder. Here we go for the Gasserian ganglion block. First, we will go for the diagnostic block, and then if it is confirmed, we can go for the radiofrequency ablation for the trigeminal neuralgia, and that is also very common. For the cluster headache, we all know the block that works in the cluster headache are two things, basically to apart from the medications. Medications, we all know sumatriptan is one medication that is very useful in the terminating the cluster headache and migraine both. Okay, in sphenopalatine block, and what are the other techniques, among which one is the oxygen inhalation, 100% oxygen inhalation for 15 minutes that relieves the cluster headache pain. And another thing is important for the relief of the cluster headache pain is the sphenopalatine ganglion diagnostic block. It is a very simple technique, just putting a cotton swab and putting it inside the nose and going to the lateral side. Okay, just posterior to the middle turbinate, you need to reach with this cotton swab with at least 4% of the xylocaine. Okay, you may give 4 to 10% of the xylocaine, and the drugs diffuses into the sphenopalatine ganglion, and that gives the relief. Okay, so that is one of the important indication for the sphenopalatine ganglion block. Now, nowadays I was seeing in one of my college group, that means in anesthesiology, we are using it for PDPH, but in PDPH, you can give it only for a small duration of time as it is a diagnostic block. Okay. Oh, and I have seen some studies are also there. So cervicogenic headache, there may be condition that is the C2 C3 medial branch block, okay, because it ultimately goes to the head in the form of third occipital nerve. So if there is third occipital neuralgia, that can give rise to the cervicogenic headache, okay. So in those cases, we need to go for the C2 C3 medial branch block to find out where the headache is. Next is the cervical and scapular myofascial pain syndrome. If it is suspected, then we need to go for the trigger point injection. Internal disc disruption or radicular pain in the cervical canal, we can go for the cervical epidural. So these are the diagnostic interventions we perform in case of the headaches. So this was the general outline for the headache. So if you have any question in this general outline, you can ask me a question, or then I will go to the specific headache disorders in very short, okay? Otherwise, it will take a lot of time.
I feel you can complete the whole of this headache discussions and then you can ask the questions.
Okay.
And as you told, discussing headache in 1 hour time is almost
very difficult. It's very difficult.
So just it is just outline. And again, we'll be telling that headache evaluation. There is two our earlier YouTube channel lectures are there. So you can go into the YouTube channel, the Rodya Pen Clinic YouTube channel. You can get the headache evaluation. Some class by Devjyoti, some by us are there. So you can search those lectures and you can go through those.
Okay, so I'm going directly to the diagnosis, okay? Because the initial part I have discussed with the general class of headache. So according to the International Headache Society, they have laid the guidelines. So first is the two types. One is the migraine without aura, that is the common migraine, and migraine with aura, that is the classic migraine I have already told. Then in migraine, we, for saying it is a common migraine, we need to at least get this minimal criteria. At least 5 attacks per year that last for 4 to 72 hours of duration. At least 2 of the following symptoms, like that is pain in one side of the head, pulsating and throbbing pain, moderate to severe intensity that inhibits or prohibits one's ability to work, aggravation of pain by physical activity, by climbing stairs, etc. Okay, among these 4 symptoms, we should get at least 2 symptoms. Next, we should get at least one of the following symptoms like nausea or vomiting or light sound sensitivity. I have already told the patient prefers to go in a cold, calm room with dark room basically. So because here the patient cannot tolerate this light or sound, and their patient might either have nausea or vomiting. So at least one of the following symptoms, these symptoms must be present, and no evidence of any other disease that could explain these symptoms. So we need to go for an imaging study as well, and we need to exclude that there is no other disorders attributing to this disease. And this is the criteria for the classic migraine. Okay, at least 2 attacks per year, at least 3 of the following symptoms, 1 or more of the following aura symptoms. Okay, so there are a lot of aura symptoms that when you'll be seeing the video, you can read, or you can directly go to the ICHD site and there is written clearly. Then gradual development of at least one of the aura symptoms or more in more than 4 minutes, or 2 or more symptoms that occur at the same time, aura symptoms that last for more than 60 minutes, headache that occurs simultaneously with aura symptoms or follows aura symptoms within 60 minutes. So if they are present, okay, then we should consider among these 4 criteria are present, then we should consider that this is a classic migraine. Now, there are 4 phases. First of all, the first phase of prodrome, then phase of aura, then phase of migraine headache, and the phase of postdrome. Okay. So it will be a long class. I am skipping these things. Okay. Now coming to the management. Okay. So migraine management is, there are 2 ways. That means 2 types of medications. One type of medications are the preventive medications. If you take these medications, the number of attacks will reduce, and it will also reduce the intensity of the attacks. So what we commonly do to the patient or ask to the patient as immediately after taking these prophylactic medications, headache do not go. So it is difficult for the patient and for you to assess whether the headache is reducing or not. So in those conditions, what we do, ask patient to maintain a headache diary. So what is that headache diary? In here, it is a very simple thing. Just write the date and rate your headache, or you just give marks to your headache. If it is massive or very severe, then give it 10. If it is no headache on that day, give 0. Okay, so simple thing. And ask the patient to take that recording after a month. Then you will be able to understand whether the number of attacks or intensity is reducing over time or not. Depending on that, we need to adjust our medications. Now coming to the medications, what are the commonly prescribed medications for migraine? So commonly prescribed are the flunarizine. Flunarizine usually prescribed 5 to 20 milligram. Propranolol usually prescribed at 80 milligram, usually started at the 40 milligram, and then it is increased up to 80 milligram, can be increased further as well. Methotrexate nowadays more not commonly used. Amitriptyline is commonly used. Usually the initial starting dose is 10 milligram and increased up to 25 milligram. Carbamazepine in general for migraine is not used, but it is commonly used for the trigeminal neuralgia. Divalproex sodium commonly used, and here the usual dose is the 250 milligram, and usually nowadays the OD preparations, once a day preparations are available. So usually we start with 250 milligram once a day, then we increase to 50 milligram twice a day. Then topiramate. So topiramate is another new drug where we should start from the 25 milligram, and we can increase up to commonly up to 100 milligram. Okay, and usually we give it in divided dosage. So these are drugs we commonly use, among which you should know propranolol, the side effect, the heart rate might go down, it's a beta blocker, and there is some amount of depression might occur with the propranolol. Amitriptyline common things, what we get is the anticholinergic effects, increase in heart rate, and the dryness of the mouth. There might be, if the patient is having the BHP or the aged patient with the cardiac problem, you might need to avoid these drugs. Divalproex sodium commonly used. You should, especially patient at the childbearing age, you should avoid this. And here we should start with a 250 milligram dose, then we should increase. And topiramate, here we should consider the chance of angle closure glaucoma, and here the topiramate is the drug that can reduce the weight. So in case of the patient is fat and having the migraine, you can easily use the topiramate. Okay, so at the interventional pain management techniques you can use for the chronic migraines, and here it is indicated for the botulinum toxin for the scalp to prevent the migraine attack for the prolonged period. Okay, and we need to consider these things. That means whether there is the migraine triggers are present or not. If they are present, patient is asked to avoid these migraine triggers. That is very much important. So for the abortive management, the drugs we commonly prescribe, the first drug is the paracetamol, usually 1000 milligram is given. And if it is not responding with the paracetamol, then we can go for the argatamine derivatives, or we can go for the sumatriptan, zolmitriptan, etc. And here, usually we can give tablet, or if the patient is having vomiting associated, then we can go for the intranasal preparation as well. Okay, usually for the sumatriptan, zolmitriptan, all intranasal sprays are available. So these are the drugs that is used for the abortive management for the migraine. So that was in short migraine. Now
Jyoti, there is a question in the chat box about the sphenopalatine ganglion intranasal. So when you'll be demonstrating, you can just show, or anytime you can just tell this how to do this. Very simple technique.
okay, it is a very simple technique in which what is commonly done is that, just a minute, I think okay, sphenopalatine. as there is a question, I'm just showing one slide but you can understand how to perform it. Okay. So I am not going into the detail lecture because it is a long part and it is not for the basic, but definitely the diagnostic part is very, very basic. So in the diagnostic part, what is done is this. Can you see this? Okay. So what is there? This is a cotton swab. Now, this cotton swab, we have soaked this portion with lignocaine, 4% or 10% lignocaine. Previously in India, the lignocaine, what is available in spray, 10%, they have a metal small tip. So I have done in few cases where I have directly put that metal tip inside the nose and then sprayed in just posterior to the medial meatus. So that was possible. But nowadays they all comes with plastic tips which are large, so that is not possible. Here we take a cotton swab and then soak it with xylocaine and then place it here at the lateral part of the nose. That means you have to go to the middle meatus, just posterior to the middle meatus. So it is not understandable, in fact, when we are putting. So we need to put it like that, then we need to go laterally and hold it for 2-3 minutes so that the drug gets time for the diffusion. Okay. And if you continue to do that, then there will be relief in pain. Okay. So that was the simple technique of Gasserian ganglion diagnostic block.
Not Gasserian ganglion.
Sorry, not Gasserian, cerebrospinal ganglion. Sorry. Now coming to the cluster headache. Now cluster headache, as I have told, cluster headache is also known as the alarm clock type of headache. So almost everyone on heart type of the headache, one of the life. So these are the basic of the day. So age group is affecting 20 to 45 years and males are much more affected than the females, 4:1. Prevalence is 0.5 to 1 per thousand. And there is bouts of headache occurs in early spring or autumn, then it goes off. Okay. So it comes in a cyclical pattern. And even within the day, it comes in a cyclical pattern. Okay. Sometimes the patient says that I am having pain at night at 8 p.m. or 6 p.m. between 6 p.m. to 8 p.m. Or sometimes there might be condition, the frequency vary, but this alarm clock type pattern is present in most of the patients. Okay. Now, precipitating factors, stored meat, cheese, MSG, excess cold heat, certain type of chocolates, they can precipitate this headache. Now, the characteristic of headache is that the unilateral sharp piercing pain around or behind the eyes, lasts from 15 minutes to 180 minutes. Pain is often with the ipsilateral signs of the autonomic disturbance. Okay. So it is also known as the alarm clock type of headache. Each attack lasts for 15 to 180 minutes. 6 to 8 times of a day, the attack might come. Okay. Starts usually at the same time every day. This is an important characteristic and often seen after onset of the REM sleep. Okay. So this is the type of headache and symptoms. These are the autonomic symptoms. What are the autonomic symptoms? That means there is the redness of the eyes. Okay. The congestion, then nasal stiffness, constricted pupil. Okay, this might occur in case of this cluster headache. Systemic features of the cluster headache might be vertigo, bradycardia, increased GI acid production, hypertension, syncope. So that might occur with the headache. Now, diagnostic criteria. Again, this is the ICHD classification criteria, IHD criteria. At least 5 attacks fulfilling the stage B to D. B is the severe unilateral orbital, supraorbital, or the temporal pain, lasting for 15 minutes to 3 hours untreated. Headache associated with at least one of the following signs: that the conjunctival ingestion, lacrimation, nasal congestion, rhinorrhea, forehead facial sweating, miosis, ptosis, eyelid edema. Frequency from 1 attack every day to 8 per day. or one attack every other day, every 2 days to 8 per day. Okay. Episodic type 80%, at least 2 cluster periods having 7 to 365 days, spreading by a pain-free remission of more than 1 month, and chronic time, there may be pain-free remission that should be less than 3 weeks. Okay. So differential diagnosis, we need to differentiate it from the trigeminal neuralgia, herpes zoster, sinusitis, temporal arteritis, carotid artery dissection, aneurysm rupture. So we need to differentiate it. Okay. Now for the abortive therapy, as I've already told, 100% oxygen, 10 to 12 liters per minute for 15 minutes. That helps in reducing the headache using a non-breathing mask. Okay. Otherwise, it is difficult to achieve this concentration. Most efficacious with the headache when it is at the peak. Sumatriptan 6 milligrams subcutaneously, or sumatriptan nasal spray 20 milligram, or zolmitriptan or dihydroargatamine. So this can be used for aborting the drug. Now coming to the prophylactic medicines for the cluster headache. Now if we go for the evidence, okay, the most evidence based is the verapamil. Okay, that is a calcium channel blocker, and it is given usually started with the 80 milligram 3 times a day or 40 milligram 3 times a day, and increased up to 480 milligram per day, and can be increased up to 720 milligram per day. Monitoring of the ECG and checking the cardiac side effect is to be done when it needs to be started, but it takes time to act. Now coming to the lithium, I don't think it is now used much, but there were some studies with the lithium as well. But nowadays we are not practicing using lithium because the drug is having very poor safety margin. Okay, if you give lithium, you need to keep monitoring the blood sugar level, and when there is acute phases, then there are use of steroids. Okay, here steroids are used quite commonly by the neurologist, but remember, the use of steroid in this condition is not evidence based, though it is a common practice everywhere. And combination of the drugs work more than the monotherapy. So prophylactic of the coronary, again, prednisolone, yes, it is not evidence based, but commonly practiced, and it gives result when there is successive attacks or acute attacks. Okay, argatamine titrate, okay, sublingually, this works. Dihydroargatamine, that also works. Okay, and other options are the melatonin 10 milligram at night, topiramate, gabapentin, diverpret sodium. Especially in those cases, actually no drug works very beautifully. So there are a lot of things tried. If they are not responding, nothing is responding, okay, the patient is refractory, then we can go for the pterygopalatine ganglion block. Okay, and if you are getting a good relief with the diagnostic block, we can go for the speech beat block from the lateral approach. Okay, and here we need to block it with the radio frequency lesioning or the glycerol rhizotomy. So here we can block this phenylpalatine ganglia for the treatment. Okay, so this was the cotton applicator. This is another approach that is not, there is a greater palatine foramen approach of the phenylpalatine ganglion block that is not performed nowadays. This is the approach what we commonly perform for the lateral approach. Okay, we go from the lateral side, then we go to the phenylpalatine pterygopalatine fossa, and then we inject drug there. Okay, so this is the needle position and this is the dye distribution. So I am not going into the detail because it's a basic course and you are not going to practice only this type of knowledge unless and until you are practiced with the CM procedures, then only you can go. But you should know these are the things, and you should know the medical management of this condition. Okay, so these are the things that needs to be done. Okay, so that's more or less concludes the most common type of the headaches. Okay, so if you have any question. Okay, a lot of questions here were there by but Sarah and Chinmayda has answered most. If any other question is there from you, you can ask me.
So, Deputy, I used to add few things that as a pain physician, everybody should know migraine very nicely because, very frequently, as the Deputy already told, migraine is the commonest headache for which a patient visits a doctor. Normally, tension type headache patient do not visit a doctor because that is mild in nature. but you must be knowing the migraine very thoroughly. You have to learn it very nicely. And apart from it, though you'll be getting very rarely this what is this called? Last one, this headache. Everything what you told last time.
Cluster headache.
Cluster headache.
Nice. Cluster headache is very rare, but you need to know it because cluster headache has very important evidence for the cerebrospinal ganglion problem. So
In fact,
because
I'm
it has
sure.
a very important role, that is why you must be knowing it, but it is very rare. In my practice, I can tell that only I have seen 5-6 cases of cluster headache. It's very rare. And another very important thing, what you have to know is the cervicogenic headache. Cervicogenic headache is mostly because of the third occipital neuralgia or cervical facet. So the other things where very important role of the interventions are there. So cervicogenic headache also is another area where you have to make a diagnosis. But what is very important is all of you must know very nicely about the migraine headache.
And actually what I was telling, right now I have a patient of the cluster headache. So she has visited, she is a female and she has visited lot of neurologists, and ultimately now she got relief with oxygen. So the thing is, here when I suggested oxygen in this time, so she was not getting any oxygen because all cylinders are booked for the patients of this COVID. Finally, she managed to get an oxygen cylinder and she is now good with the oxygen inhalation. So she might come in 1 or 2 weeks for the diagnostic phenylpalatine ganglion block. Okay. So the thing is, these are rare, but the result of this oxygen inhalation and the phenylpalatine ganglion block is dramatic. So that is
there is another question of SNRI antidepressant in the migraine headache. So that is not a primary drug. Primary drug already, but SNRI can be a supportive group of drugs. Sometimes we give duloxetine as a supportive drug in the migraine, but migraine prophylaxis and migraine abortive drug antidepressant has supportive role only, but they are not the primary drug.
Sir, I have a question, sir.
yes.
Sir, among all first line prophylactic drugs of migraine, how you choose? What will be our approach of choosing?
Actually, this approach practically changing with time to time. Initially, the first line was considered the beta blocker, okay, or flunarizine. But nowadays, the latter it was changed to the valproate, and now it has moved to the topiramate. Okay, so it depending on the evidence and time, it is changing. So nowadays, most of the neurologists consider it topiramate. But again,
anyway, they should know that you should know that this out of these 4, you should use any one. Out of these 4, what just be told, either beta blocker, propranolol, or your flunarizine, or your divalproate sodium, or your topiramate. So these are the 4 drugs. Out of these 4, choose at least any one of your choice.
Okay, sir, is there any sedative side effect of topiramate?
Yes, sedative side effect is there, and some patients might get initially say that what you need to do, you need to just reduce the dose. Whenever you're starting this type of drugs, okay, start from a lower dose, because even the valproate, if you give 500, the patient may not tolerate. So initially start with the 25 milligram at night, gradually after 3-4 days increase to 25 milligram twice a day, then go for the 50 milligram twice a day, 50 milligram at night. That way, 1 by 1 tablet you should be increasing. Otherwise, the patient compliance may not be good.
And sir, is there any indication for combination therapy for among the first line drugs?
Okay. Usually, here in the migraine, the monotherapy is chosen first. Okay. If monotherapy fails, then we should only consider the combination therapies.
Okay, sir, thank you.
In fact, in commercially, there are some certain combinations with available. Some of the like divalproates and propranolol. But we always tell that okay, monotherapy is better. If you wish to add another, you wish another. Combination therapy is most of the literature they do not recommend. But if one drug has not getting the very good result, then definitely you can either switch over to the another, or you can use the combination. But sir, initially you should always start with the one single drug at adequate dose, and then you should consider whether it is working or not.
Sir, how long we should try before switching to a second line drug?
No, majority of the drugs, they take some few weeks. So at least you should try 1 month, at least. then only you can think of switching over the others.
Okay, sir. Thank you, sir.
So next class is also mine, trigeminal neuralgia, but I am switching a little. Chinmada is taking first because I am talking for long. So Chinmada will first take the postherpetic neuralgia, then I will talk on the trigeminal neuralgia.
Okay. Sir, you can hear me?
Yes, we can hear. And before you start, I should be telling audience one thing, that there are certain problems which are considered as this is our problem, our disease. Means like a cleft palate, who should be operating? A thyroid, who should be operating? There might be the fight between an ENT surgeon, a plastic surgeon. So same way, who should treat this prolapse pain? So there might be a fight. Who might be treating the headache, like whether a neurologist or a pain physician? But post-herpetic neuralgia is one such condition which are primarily treated by a pain physician. So learned very nicely. Post-herpetic neuralgia is very problematic case, and there are few conditions which are typically should be managed by a pain physician. Post-herpetic neuralgia is one of them.
Okay. Sir, I am audible, no?
Yes, you are audible.
Okay. So this topic is post-herpetic neuralgia. Okay. So first few things. So this is herpetic lesions. These are characteristic herpetic lesions. There should not be any confusion. This type of patient sometimes can come to us. But of course, we are not much interested in treating acute herpes zoster. We are more interested in treating post-herpetic neuralgia. So we will take history from the patient most of the time, that whether you developed this type of lesion or not. So an episode of herpes zoster is a prerequisite for the development of post-herpetic neuralgia. So our history should give as the clue that patient had a herpes zoster. Then what type of rashes usually we get? Rashes is unilateral most of the time, with blisters in a dermatomal pattern in history. Here the most important thing is blisters in a dermatomal pattern. Okay, so some nerve root, some intercostal nerve root may be affected in this case. Okay, so that's why it is the blisters in a dermatomal pattern. Okay. So risk factor. Here, risk factor can be of two risk factor. For risk factor for two different things. One is herpes zoster, risk factor for having herpes zoster, and second is risk factor for post-herpetic neuralgia. So risk factor for herpes zoster universally accepted is age and immunosuppression. Usually both go hand in hand. So, but then more age means there is more risk of having herpes zoster and immunosuppression for any reason. Okay, 13% of patients older than or equal to 50 years of age with herpes zoster would go on to develop post-herpetic neuralgia. So risk factor of post-herpetic neuralgia after someone has developed is again age and severe immunosuppression and presence of a prodromal phase, then severe pain during zoster outbreak and allodynia, ophthalmic involvement, and diabetes mellitus. So here in one part we have a role, that is severe pain during zoster outbreak or allodynia. Here we have some role when the patient has herpes zoster. All other things actually we don't have any other rule. Okay, so we can act like in prevention of post-herpetic neuralgia. So what happens here? Here varicella zoster virus lays dormant in the ganglia of certain peripheral and central nerves. Okay, after an episode of varicella resolves, usually in childhood or up to 16-17 years, everyone gets chickenpox infection, where varicella zoster infection, mostly it is chickenpox, as chickenpox. And so this virus ultimately our immune system, that clears all the viruses from the blood, but still some virus lays dormant in the ganglia and advance as soon as again time comes when there is a immunosuppression. Advancing age combined with a decrease in immunocompetence, usually accompanied by psychological or physical stressor, may result in reactivation of the dormant or latent varicella zoster virus. And the virus replicates and travels down axons until it reaches the skin, where blistering, erythema, or local inflammation occurs. So you have understood what happens. No, first chickenpox will be we get chickenpox in our childhood, then it is there in the ganglion, nerve ganglions, and ganglion of the peripheral or central nerves, whatever, and then it reactivates due to some reason. Then we get the varicella zoster attack of herpes zoster. So virus is same. In childhood it is chickenpox, in adult it is herpes zoster, and then after herpes zoster we get post herpetic neuralgia. Both have different risk factors. So pathophysiology, for everything, I mean, like pathophysiology is not well understood. So histology of when it was done, then it showed that myelin and axon deficiency as well as atrophy of dorsal horn is there. And then so some amount of anatomical dearrangement is there in post-herpetic neuralgia. Most of the time in neuropathic pain, we don't get any anatomical derangement. It is a physiological derangement. But here in this neuropathic pain, anatomical derangement also some degree is there, at least partially responsible. And then some other thought is that that an inflammatory response at the neuronal level may also be the main culprit of the eventual development of post-herpetic neuralgia. So specifically via the reduction of centrally mediated inhibition of nociceptive input and promotion of peripheral sensitization via damaged nociceptors. So what yesterday I told, those things also, I mean, like it is ultimately a neuropathic pain. So there is a part of sensitization and that inhibitory modulation which we have normally in our body, that modulation part goes, I mean, it is a reduction of centrally mediated inhibition of nociceptive input. It works less. So the pain, it appears more. And in post-herpetic neuralgia, allodynia is a very important sign symptom, you can say. So
hello sir, your skin is not visible, sir. Yours.
Hello.
Yes sir, screen is not, it's showing has started screen sharing. Many of us are having the same problem.
Sir, you cannot see?
No sir, no sir, we cannot see. It's showing Chinmoy has started screen sharing. Now it's coming, now it's coming.
Now coming. So I mean till okay, till which slide? This you have seen earlier? This part?
No sir, no sir.
Yes, sir. Yes, sir.
Oh, some people.
Yes, sir. This was seen.
Okay. So I mean, maybe there is some, yeah, I mean, like internet connection, it can differ in different areas. So anyway, so okay, so mainly you have understood that these are the pathophysiology, that ultimately myelin and axon deficiency will be there, and some anatomical derangement. Why I have underlined it? Because in neuropathic pain, many times anatomy is normal, pathological physiological problem is the main thing. Physiological derangement causes the neuropathic pain, but in this case some anatomical derangement has also been found. And another school of thought, you can say, that inflammatory response at the neuronal level is the main culprit of eventual development of post-herpetic neuralgia, specifically via the reduction of centrally mediated inhibition of nociceptive input. So This is the which I told you last day, that transduction, transmission, perception, and there is a neuromodulation part. This modulation is inhibitory neuromodulation is normally present in our body. So if that modulation, there is a reduction of this modulation action, then patient will get more pain than it should get. And then promotion of peripheral sensitization. So this sensitization will also increase the perception of pain. Okay. So ultimately it is a neuropathic pain. This is okay. Same thing what I have said. Okay. By definition, persistent greater or equal to 3 months of lancinating burning pain, allodynia, paresthesia, dysesthesia, pruritus, and or hyperalgesia at or near the area of the rash is the hallmark of post-herpetic neuralgia. So most of the time, patient with rashes don't come to us. That is the acute herpes zoster. So there they will go to infection specialist and all. When they will come, you will get the history that they had rashes there, where now it is paining, and you may get earlier only there is some marks, scar marks or something that will tell you that okay, this part was I mean blisters were there, but now it is healed. We get the patients in that stage, and what patient will complain, even patient will not be able to put their cloths on that part. Even the cloth touches on that part of the skin, patient will get pain. So that is called allodynia, because cloth ultimately should not cause pain. So any non-painful stimuli causing pain is allodynia. And paresthesia, dysesthesia, pruritus, and hyperalgesia. Hyperalgesia is, if you want, I mean, like, give a small pain stimulus, patient will cry, start crying. So that is hyperalgesia. Okay. So basically, diagnosis is by history and physical examination. There is no such, I mean, like, investigation objectively seen that how that it is a post-herpetic neuralgia. Most of the time in the pain cases, I mean, this is a by subjective, it is a subjective feeling. Pain is subjective feeling. So history and physical examination is sufficient with history of herpes zoster. Okay. And less commonly used, these things are not done in our practice. This is only scientific, I mean, for any study purpose you can do. Immunofluorescence of the vesicle scraping detects herpes zoster virus antigen, or PCR study, or MRI study even. MRI study of the nerve roots mainly and ganglion area. That also can give some clue that this is the herpes zoster infection. And where we need these studies, if there is a doubt in our diagnosis. So if it is in face, always remember trigeminal neuralgia and Bell's palsy should be considered. In thoracic dermatome may infrequently be appendicitis, cholelithiasis, or colitis. Atypical atypical is zoster cyni herpeti, shingles of the larynx. So what is this zoster cyni herpeti? This is the zoster of cranial nerves, and without any skin rash, without the typical skin rash, but still I mean, like, herpes has affected a cranial nerve. So that is possible. So this is a atypical condition. You should just know that I mean, this condition is present. This is possible. Shingles of the larynx, patient may lose his voice suddenly. So those things, these are atypical presentations. And if diagnosis of post-herpetic neuralgia is unclear in those cases, then serological study for herpes zoster virus may be beneficial. Otherwise, nobody goes for serological tests. Ramsay-Hunt syndrome in a zoster patient, this is Ramsay-Hunt syndrome is also can be seen. I mean, there are triads like if you will see the zoster vesicles here in the ear lobules or in the auditory canal, and then one side facial paralysis. This side is paralyzed because the angle of the mouth is directed to the opposite side, and another was tingling of the anterior two-third of the tongue. Okay, so that is also possible in herpes zoster. So management, there is 3 fundamental treatment approaches. First, prevention by vaccine, which is not in our hand. We as a pain physician, we will not handle with this thing. But then this is the one approach. First is prevention by vaccine. Whom to give the vaccine? Those who are at risk groups. Okay. Second is early recognition and treatment of an acute herpes zoster infection, as delay may increase the chance of developing post-herpetic neuralgia, which I was saying that if sometimes you get some acute herpes zoster infection for pain, I mean, like treating infection specialist sends to you or dermatologist sends to you saying that if you can do something for this patient, then of course you can treat that patient. I mean, like mainly by intervention, because other medicines they will also be giving by intervention, so that treating that acute part will also prevent post-herpetic neuralgia. And third approach is symptom management of post-herpetic neuralgia via multimodal medications, regimens, I mean, like interventional procedure, everything. So those things. Last day, actually, I showed you one who ladder approach. No, so here this is a severe pain, and so we will start the at the letter 4 approaches. I mean, like intervention, medicine, everything will give to decrease the pain. Now, treatment of post-herpetic analgesia for symptomatic management. This is very frustrating, of course, because though many medicines are there, but ultimately patient only gets a moderate pain relief, not too much. So oral, as for any neuropathic pain, though it is a specific diagnosis post-herpetic neuralgia, but the treatment is all neuropathic pain is nearly same, approximately same. Only say trigeminal neuralgia, you will go start with carbamazepine. That is a different issue. But otherwise, all neuropathic pain have a normal treatment. I mean, have a similar treatment algorithm. So, what are the treatments? This TCA, tricyclic antidepressant. This will act. You remember, this will act as in the modulation path. Okay, it will increase the inhibitory modulation. Pregabalin, it will act at calcium channel. Opioid, so it will also modulate in transmission part. It will actually act at transmission part by the mu receptors or other receptors, opioid receptors. So these are oral medicines. Topical, so this topical is again specific for post-herpetic neuralgia patients when the I mean, area is completely healed. This is not for acute herpes zoster. When the area is completely healed, you can use 5% lidocaine patch or 8% capsaicin patch. So, an intervention, many interventions have been tried, but only epidural and intrathecal steroid injections and neuromodulation has been seen to have good effect. Good effect means moderate effect, not excellent effect. But still, epidural and intrathecal steroid injections can be tried, but not in India, because we, as far as I know, I'm not very sure how sir will say that this methylprednisolone, that one's preservative free methylprednisolone we don't have for epidural intrathecal injection. You can give only at epidural space, in the epidural space. So this you can try, or neuromodulation, spinal cord stimulation and peripheral nerve stimulation, only moderate effective, but people are doing as a study purpose, you can do. And RF of DRG, botulinum toxin injection, sympathetic blockade, many other things have been tried with not much good effect. So these are different studies. One study says effects of applying nerve block to prevent post-herpetic neuralgia in patients with acute herpes zoster. So what I was telling, that in acute herpes zoster, if you get some patient, you may try to decrease the pain in acute phase so that post-operatic neuralgia doesn't start. So that is paravertebral or repeated continuous epidural blocks, which we can do. Epidural blocks with steroid we can give repeatedly. Okay. Second thing, this is the lidocaine patch. Qutenza is our capsaicin patch. So this has different protocols. Lidocaine patch, I mean, 3 lidocaine, now 1 lidocaine patch will continue for 12 hours, and another 12 hours you will not give any lidocaine. I mean, only for 12 hours per day you can use patch, and up to 3 patch you can use. So you have to give another 12 hours to without lidocaine patch, I mean. So that lidocaine patch will act for 24 hours, but patch will remain on the body for 12 hours. Okay. So, and then Qutenza is our capsaicin. You have to use gloves also, and then you have to apply local anesthetic cream first. Then you have to start Qutenza. So you have to apply. So after that, with 1 patch, people gets around 3 months of relief. So in post-operative herpetic neuralgia, 3 months of release is a great achievement, because first 6, 7 months, 8 months, or 1 year is the main time when patient needs pain relief. Okay, then comes this is also another study came, systemic review in 2019, pain physician. So all the different interventions they have seen, these are all evidence level is level 2. So grade V recommendation. Grade V recommendation means you can do in a clinical trial setup. Okay, and these have a moderate evidence, only moderate degree of pain relief. At best moderate degree of pain relief can be achieved. Spinal cord stimulation and peripheral nerve stimulation, still that much evidence is not there to give any recommendation. Okay, so take home points: prevention is very important in post-herpetic neuralgia. Once established, can be refractory to treatment. Okay, and the pathophysiology of PHN is complex, and sometimes an individualized non-traditional approach may prove beneficial for a particular patient. This is also, we have seen sometimes that yes, some patient get good relief with intercostal nerve block also, intercostal nerve block, cryo, those things. So okay, thank you then.
So there are 2-3 questions was there. I already answered. So lidocaine patch is to be applied only the pain area. If we are applying it over the other area, it will not be effective. So you have to cut it according to the area where the pain is there, and you should be applying over there. Actually, it is for the post-herpetic neuralgia. So the normally in the post-herpetic neuralgia, cutaneous lesions are healed, vesicles are. So in that painful area, you have to apply the patch for 12 hours, and then again 12 hours you keep it out. So finally, you're getting the result that way. And 8% capsaicin patch is not available in India. So if it is applying the capsaicin cream, 0.5% or 0.1% or 1% cream, these are available in India. They are not helpful. They are not helpful. It is the 8% capsaicin patch that is needed.
Yes, sir. Thank you, sir.
Okay, today my microphone and my camera both are not working nicely. I don't know what is happening to my laptop.
So, may I ask a question, please? So then what can be the best modality for post-herpetic neuralgia when we are saying that it is controversial and non-traditional approach should be used?
Yeah, sir, you will answer this question. Your experience is much more
You
than
see,
me.
you have to the best till my experience and also literature, the lidocaine patch is the best one for the post-herpetic neuralgia. So that is the best one, but this nothing is very much evidence based. That means if you are talking about the epidurals, you are talking about the other medications like antidepressants, anticonvulsants. If you're talking about the sympathetic block, so all those things we really don't know which will be effective in which patients. So all of this has been tried. Spinal cord stimulator is difficult in our country, particularly not many patients are going for this trial. But all other things you should be trying it based on the evidences. The evidence is strongest with the this lignocaine patch. So you should be using, earlier lignocaine patch was not available in India. You know, lignocaine patch is available only last few years it is available. So now you can use the lignocaine patch as a fast modality, and along with that you can add some of the drugs like antidepressant, anticonvulsant, and even non-traditional means one of the thing is your, you know, the acupuncture. Also there are some papers that acupuncture also might be helpful. So you can try these interventions if the drugs are not giving good results.
So if a patient comes with post-herpetic neuralgia, we should first prefer to give a lignocaine patch and
Lignocaine patch
antidepressants.
and the drugs. You just start with the
And
amitriptyline
antidepressants.
and the pregabalin, this kind of combinations you should be starting.
Okay, thank you, sir.
Sir, how long we can use lignocaine patch or commonly used? How long?
You see, lignocaine patch is costly. You know, lignocaine patch gives the best result. But normally we should not say that, okay, you should be using it, because post-herpetic neuralgia can be most of the times it is, you know, resolved spontaneously. So we have to wait for that. But lignocaine patch continuously using for several months, you know exactly how many period, weeks it should be used. There is no literature telling, okay, this many days you should use it. But what we practice, that we are using the other drugs plus lignocaine patch. Once the pain is reduced, first you stop the lignocaine patch and continue the other medications. This should be your approach. For that,
Okay.
it might be 10 days, 12, 2 weeks, 10, 3 weeks. It's like that. And we are always waiting for the spontaneous, resolution, when the things are there. And meanwhile, if the drug is not effective, patch is not effective, you can get this kind of patient also. That patch is not effective, drug is not effective. Then you should try the other interventions as well along with this.
Sir, another question is about intercostal block. Actually, my experience of intercostal block is not good. What is your experience, sir?
Yes, the same thing, same thing. Most important part is intercostal nerve block can give you only few hours pain relief, not continuous, not continuous. But another thing can be done, particularly if it is in the area of the intercostal nerve, that means the thoracic dermatome. The other options are, you can try the cryoneurolysis of the nerve, intercostal nerve. That is one of the some evidence are there. This is very new, but I have done one case. Result is excellent. And other things which have been tried is your dorsal root ganglion, pulse radio frequency. That also has been tried with a mixed kind of results. But what Dr. Chinmay already told, the only one thing which is having the evidence is the epidural steroid, intrathecal steroid. These are having some evidences. Other things don't have some mixed kind of result. Means evidence-based recommendation, if you are asking what is the best one, which intervention is best one, still now we have to stick to these points, that the epidural steroid, and epidural steroid also, it is more effective in the acute case, not in the post-herpetic neuralgia. So basically, it's very mystery, very difficult cases to do, and you have to try which one is effective.
Sir, is there any role of lignocaine jelly?
Lignocaine jelly don't have any role. Lignocaine patch is effective for the 24 hours, but what Dr. Chinmay already told, you have to apply it for 12 hours and remove it for the next 12 hours. And apply it, suppose today at morning 8 a.m. you have applied it. So by evening 8 p.m. you remove it. And again, next day morning 8 a.m. you apply another patch.
And
So
sir,
for
is
how
there
many days can we apply the patch?
Blisters, sir?
How many days? Just now we discussed it. You was not there?
So I was there only. So.
We told that there is no definitive suggestions that this much days you can use. So we are waiting for the pain relief to occur. When the pain relief is adequate, we stop lignocaine patch and continue the oral medications.
No, sir. As in,
So
for
what
how long?
Now, how long means you go on? I mean, if patient can afford a patch costs around 500 rupees. So if patient can afford, yeah, or 900, no, okay, then you advise that, okay, every day he should take the patient, every day apply for 1 month, nothing will happen because
Okay.
12 hours.
Okay, sir.
Yeah.
But as soon as the pain is reduced, you stop that and switch over to the other medicines you continue.
Yes.
Okay, sir. Thank you, sir.
Even if active blisters
Sir.
are there, we can go for the patch, sir. There is no problem. Even if active blisters are there, sir.
Hello?
I could not get it, the question.
Even
Okay,
if
he is telling if there is a skin lesions, blisters are there.
No, we
Whether we
should
should
not.
Yes, sir. Active blisters are there. We can apply that patch, sir. Is there?
No. Actually, in acute blister, you cannot make diagnosis of post-traumatic neuralgia also. This is the acute herpes zoster pain. And if acute herpes zoster pain, no patch should be used if there is skin lesion.
Okay, sir. Okay, sir. Thank you, sir.
You can give in the acute lesion, if you at all do something, if you can go for the epidural. Otherwise, the acute herpes zoster, earliest you are giving the antiviral drug, you will be having the best results. So start antiviral drug immediately. And if the pain is too much, then you can give an epidural.
Steroid also they use.
Steroid also, all steroid.
Sir,
Okay, sir. Okay.
sir, what about ESP block, sir? And it's yes, what cocktail do you use?
What?
Which block?
ESP block.
Erector spiny block.
Okay.
Yes, sir.
Erectors, they see, as we are telling, that block is for anesthesia, and block will give a pain relief for few hours. We don't want to do something which will give only few hours of relief. We want, if we are doing something, patient should get relief for say weeks at least, if not months.
And that is the same reason why intercostal nerve block is not very good because it will be giving only few hours pain relief. If you are doing the ablation, you can do the cryoablation is the only one recommended. Otherwise, you can go for the DRG of the pulse radio frequency. These are the things. Otherwise, anesthetic block is going to give you a very short-term relief. And paravertebral block has some evidence, not the erectospinal block. Paravertebral and the epidural block, that too in the acute phase. Chronic phase, the evidence is very much inconclusive, not much.
After 3 months, you diagnose. And after 3 months after diagnosing, when you are giving this erector spiny block, I have never come across that anyone has tried. But of course, block at all is not needed because we don't want to treat for few hours. Okay.
Sir, when to use oral corticosteroid? And is there any chance of flare up of lesions?
Oral corticosteroid, as I told you, that we don't get these acute patients. No, when acute patients go,
even if in the acute phase, if you are getting the acute drug, antiviral and oral steroid, this is the recommendation.
Yeah, it is given by the dermatologist always.
We can also give, no issues. Okay, another same question is coming, whether intercostal nerve block is effective. We told intercostal nerve block, if you wish to do, you have to do the cryo. Otherwise, single local anesthetic and steroid is not going to give you the long-term relief. So intercostal nerve block can be done, but you have to do cryo. Okay, I think a lot of discussions, and now the other things.
Yeah.
Hello? Hello, am I audible?
Yes, you are audible, Deputy. You are audible and your slides are visible.
Hello?
Yes, Deputy, you are audible. Tomato speaker on.
Yes, sir, you're audible.
Yes, sir, you're audible.
Yes, okay. Actually, my speaker was not on. That's why I was not able to hear you. So I thought whether I am audible or not. Anyway.
Right. You are audible, nicely audible, and your slides are visible.
Okay, fine. So today, this is another topic, and this is again core area of us, trigeminal neuralgia, like herpetic, post-herpetic this pain. So let's look into a little bit on the history of trigeminal neuralgia. It is one of the oldest kind of pain that is known to mankind, and it was known from earlier time. The description of the facial pain by Ibn Sina, who was there around from 980 to 1083. In an Arabic test, we first got two types of pain syndromes, among which one is the Bell's palsy and another is the trigeminal neuralgia. So this disease is known to mankind from these early days. Next intervention or next trial of intervention was first done by the John Locke in 1677. And what he has done, he has applied sulfuric acid on the face of the patient to treat the trigeminal neuralgia. So In that way, the attempt to manage the trigeminal neuralgia was started. But the significant achievement in the management of trigeminal neuralgia was obtained for the first time when Petrus in 1902 first used alcohol for the neurolysis, and he used alcohol for the neurolysis of the trigeminal neuralgia. So that is the first time when alcohol is successfully used to manage the pain for the trigeminal neuralgia, alcohol neurolysis. Next greater achievement, even today we are practicing a lot of this technique, is the radiofrequency lesioning of the Cassidian ganglion, which was first described by the Sweet and Wespick in 1965. Retrocassidian injection of glycerol was first invented by Hickelson in 1981, and percutaneous balloon compression was first invented by Mullian and Lichter in 1978. So that was all about the history in trigeminal neuralgia. But what trigeminal neuralgia is? Which type of patient the pain the patient is suffering from? The pain is agonizing, paroxysmal, lanceolating, which is lasting for few seconds in one or more divisions of the trigeminal nerve. It is triggered by chewing, speaking, touching the face, etc. Neurological examination is usually normal, and pathophysiology, one of the mechanisms suggested is the compression of the trigeminal nerve by blood vessels. But remember, it is not always found. Okay. Now, if we see the distribution or epidemiology of the trigeminal neuralgia, we'll find it is 1.5 times more common in females than males. Peak incidence in 50 to 70 years, and 5% of the patient is having the family history. Now, according to the divisions of trigeminal ganglion, which was trigeminal, we all know, is divided into three. One is the ophthalmic, another is the maxillary, another is the mandibular. Now, the incidence is highest with the combined maxillary and mandibular, that is 32%, followed by the all three divisions and V2 alone, that is around 17%. Next, it is by V3 alone, which is around 15%, V1 plus V2 40%, 14%, and V1 alone is 4%. So that is how it is distributed. Now, what are the questions you need to ask the patient in the history to find out whether this pain is a trigeminal neuralgia or any other type of pain in the face? First question is, does the pain occur in attacks? Yes, trigeminal neuralgia occur in attacks. There may be successive attacks of pain, and it is usually started with the events that I have already told you. That means touching of the face. Praveen Gupta, please mute your microphone. Okay. Are the most of the attacks are of small duration, seconds to minutes? Yes, trigeminal neuralgia attacks are small duration from seconds to minutes. Are the attacks unilateral? Yes, in idiopathic trigeminal neuralgia, attacks are unilateral. Do the attacks occur in the region of the trigeminal nerve? Yes, it occurs in the region of the trigeminal nerve. Are there unilateral autonomic symptoms? In trigeminal neuralgia, unilateral autonomic symptoms are not present. Unilateral autonomic symptoms are the feature of the trigeminal autonomic cephalalgias. Coming to the examination, you need to go for a neurological examination of all cranial nerves, which should be found normal in the idiopathic trigeminal neuralgia. In secondary trigeminal neuralgia, features suggestive of the sepia angle tumor or multiple sclerosis might be present. Now, what are the differential diagnoses? The disease we need to differentiate from the trigeminal neuralgia are, first of all, non-specific facial pain, TMJ arthrosis, dental disorders, vascular migraine. Okay, so these four disorders commonly mimic the trigeminal neuralgia, and we need to differentiate it from the trigeminal neuralgia. Now, first coming to the non-specific facial pain, or this term is also known as the persistent idiopathic facial pain. What happens in the persistent idiopathic facial pain? It is again a pain inside the facial area, but without any standard distribution. Okay, idiopathic PMF or persistent idiopathic facial pain. Here, usually it is not follows the classic pattern of the trigeminal nerve, and it is a commonly a dull epileptic type of pain, not at all a neuralgic pain. Next comes the TMJ arthrosis. Here the problem is in the temporomandibular joint. So if you press the temporomandibular joint, the pain will be reproduced. and patient might having difficulty in opening and closing the mouth. Okay, dental disorders commonly misdiagnosed as trigeminal neuralgia, but the truth is the different. That means the patients are first diagnosed as dental disorders, and sometimes we get the patients whose tooths are removed because in thought of there might be any dental disease present. And finally, these patients, even after removal of tooth, when not responding with the treatment, then they are sent to us for the evaluation of trigeminal neuralgia or for undiagnosed pain. This is quite common, and I have found at least 8 to 10 cases of such where tooth is extracted but because it was thought a dental disorder, but ultimately the patient was suffering from the trigeminal neuralgia. And vascular migraine, that is another thing we need to differentiate from the trigeminal neuralgia. Next, coming to the practicing algorithm. So whenever we are getting patients suspecting trigeminal neuralgia, we should not forget to do an MRI scan with the trigeminal neuralgia protocol. So we need to find out whether any apparent vessels present or not, whether any tumor or CP angle tumor is present or not. That's why the MRI is more important than CT scan, and we usually ask for the MRI, not for the CT scan. So you might get a abnormalities. What abnormalities I have already got in some patients? I got a aberrant vertebral artery. Common is the aberrant from the posterior cerebral. So these are common arteries that can place on the trigeminal root entry zone. Next, we need to go for the check for the differential diagnosis and rule out whether the trigeminal neuralgia is present or not. Now, if we go for the practicing algorithm, first, when we have diagnosed a trigeminal neuralgia, we have done the MRI. Next, we need to start the treatment in the form of medical management. Now, what are the medical management commonly used for trigeminal neuralgia? So this is the drug. The first drug of choice is the carbamazepine. Okay, usually effective dose is 400 to 800 milligram per day. Again, the sedation, GI upset, the other side effects. So carbamazepine, we should not start from such high doses. Usually it is started 200 milligram once a day with the sustained release preparation. Then it is, I always start like that, then increase with the 200 milligram twice a day, and then thrice a day, then four times. So we can increase that way of the carbamazepine. Now, if the patient is not responding with the carbamazepine, the next drug to try is the oxcarbazepine. Oxcarbazepine, usually effective dose is something between 900 to 1800 milligram, but in some patients still below this dose, the start action works. So I usually start with the 150 milligram once daily dosing with the sustained release preparation, then gradually increase according to the response. Okay, or even in some patients you can start with the 50 milligram thrice a day for the initially. Okay, next drugs which is commonly tried is the gabapentin, though as per evidence based, you see carbamazepine is the first, next goes to the oxcarbazepine, and third goes to the gabapentin, and usual dose is 900 to 2400 milligram per day, but usually it is not given at such a high dose. It is started with 300 or 450 milligram, then gradually it is increased. Phenytoin is another drug, can be tried, but in most of the cases we do not use the phenytoin, we use the other three drugs. Another drug which is not a neuropathic medication in other areas, but which is actually a muscle relaxant, but that works in trigeminal neuralgia, is the baclofen. And the starting dose for the baclofen is the 5 milligram orally 3 times a day. But you can start with, if you are using sustained release preparation, you can start with the 10 milligram sustained release preparation and then gradually increase the dose up to 40 to 80 milligram per day, total daily dose. Okay, so these are the management for the trigeminal neuralgia. Here also, the initial part is the same. That means monotherapy is preferred over the multiple drugs. But if monotherapy is not giving the desired result, we can go for the combination therapies. Now, if the patient is not able to tolerate medications or patient is getting insufficient relief with the medications, then we need to go for the interventional management. So what invasive or interventional management we can offer? If the patient is young, the treatment of choice is microvascular decompression. If the patient is elderly, the best treatment is either radiofrequency ablation or a balloon compression. Okay. Now, so what are the treatment options we have? Surgical microvascular decompression, as I've already told, this is especially good for the young patient. Stereotactic radiation therapy or gamma knife therapy, though this therapy is showing some promise, but problem is that the duration of pain relief is very low. Okay, so it is not giving a very long duration of pain relief. So, and the action is also takes time to occur. So that is why it is not becoming that much popular. Percutaneous balloon microcompression is another technique that is practiced for the trigeminal neuralgia. Percutaneous glycerol hydrolysis, when we do not have RF, even in when I used to practice in a government hospital in West Bengal, at that time I used to do a lot of glycerol hydrolysis, because here it is very simple. You just need a needle and a glycerol. Okay, glycerol is usually found in the laboratory reagents, so you can take 100% and use that. Okay, in percutaneous radiofrequency and gastrin ganglion stimulation, which is experimental. Even today, we are not doing that. So, what are the choice? We commonly do the percutaneous RF nowadays, and second, we commonly do the percutaneous glycerol hydrolysis. Nowadays, we are not doing, because once you have RF, then these things are, the duration of pain relief with the glycerol is much less than the RF. So, RF is preferred. Now, coming. Actually, in the basic course, we are not going to describe this procedure. Again, this procedure is comparatively advanced level of procedure that needs to be addressed after only you have practiced 3 to 5 years, because here the location is such that if you go slightly in, so this is the ganglion and this is the foramen ovale, this is the foramen rotundum, this is the supraorbital fissure. So in case you miss the ganglion, we will directly hit the midbrain or the pons. Okay, so that is why this procedure is a very I think advanced procedure and should not be tried at the initial part, but you can do the medical management. I am not going into detail of the description of this procedure, as we are not suggesting for the basic candidates to perform this procedure, because this procedure is risky, and unless and until it is done in a very careful hands, that might land up in complications. Okay, so I am just skipping those procedural details, but what is most important is that the diagnosis. As a beginner, you should diagnose the things properly. You should start proper medical management, and then if required, you can refer to the adequate center for the gastrin ganglion rhizolysis or a microvascular decompression, depending on the patient you are getting. Okay, you should be knowing these procedures are there and it can be treated. The disease can be treated with this procedure. So coming to a little bit about the complications, but before that, advantage, disadvantage. So here, what will be found, according to, if you see in the duration perspective, then definitely RF is the better choice, and glycerol rhizolysis is the poorest. If we think of the sensory loss, then definitely RF is the worst choice, whereas the balloon and glycerol is comparatively better. If you think of the motor deficit, then this balloon compression is the worst. You can go for the RF and glycerol. Okay, and these are the complications like carotid artery puncture, retrovalvular hematoma. Hematoma of the cheek is a very common complication. Meningitis, if there is infection occurs, then there might be meningitis. So that's all about the trigeminal neuralgia for the basic. Any questions?
There are some questions I already answered. One of the question was, when should we go for the interventions? How long should we use medications? I already answered it.
Told actually in my presentation.
Yes.
Okay. So let's move to the discography. As there are
Sir,
no
one question.
Yes.
Sir, I want to ask that when we are giving the patient treating with oxcarbazepine or carbamazepine, so how at what interval should we go for any blood test, like the complete blood count or something?
Yes, at the beginning and then every 6 months.
And sir, which one are we? Is there any preference of oxcarbazepine over carbamazepine?
Carbamazepine is the first choice. If it is the patient is not responding or not tolerating carbamazepine, then next drug is the oxcarbazepine.
Okay, sir. Thank you.
In fact, I have a publication on that. Okay, this carbamazepine long-term use, the patient was not taking for the trigeminal neuralgia, but the patient was taking carbamazepine for 2.5 years for the convulsion disorders, and these patients ultimately landed up with the cerebral hematoma. So that this presentation I have already published. Okay, if you search complication of carbamazepine, you will get that.
Okay, sir.
next part. So next thing is the discography. Actually today it is a little bit exhaustive because lot of the topics there today and different topics, lot of topics from the head, one from the herpes, and this is the last topic. Here we will be demonstrating also how to do the discography. So let's start the theory part. Okay. So in simple words, what discography is, it is very simple. We have to prove that disk is a pain generator. That is our assumption, is that the disk might be a pain generator. How we can find that the disk is a pain generator? So we all know in disk only the outer portion of the annulus having the nerves, having the vessels. Inner side there are no nerves, no vessels. So disk, if it is normal, it is not a pain generator. But the problem is the patient you are suspecting is having discogenic pain, but you have no way to prove that disc is pain generator. Then how you can say it is a discogenic pain? Because if you see the MRI changes, MRI is found to demonstrate an abnormal disc approximately in 28% of the subjects without any back pain or sciatica. So just do a 50-year aged male or female, just do an MRI and you will be find out lot of degenerative changes. The clear annular nucleus, this nucleus margin is lost. Inner part you might get black, but the patient is pain free. This is one of the common finding. Another finding is also there. When the disc is looking on MRI, a good healthy disc, but still the pain is there. So here our answer is discography. Discography is the way to prove that this disc is no longer a pain-free disc. Now this disc is sensitized. Now it has the pain receptors and it is now has become painful. So how we can prove that? So with the discography, what is discography? Discography is the injection and imaging of the intravertebral disc with radio opaque contrast. So we will be putting a contrast agent inside the disc and we will be checking whether the annulus layers are good or not. But if we see only this objective part, okay, here we are saying the disc as an object. Okay, we are putting the dye and we are taking a CT and we are checking whether these fissures, cracks are there or not. Even then, it doesn't prove that this disc is painful. So what we need to do? We need to go for a controlled increase in pressure inside the disc to prove that the disc is painful. And when we are increasing the intradiscal pressure, the disc is causing the concordant pain. That means the patient, the pain is suffering, can be reproduced by increasing the intradiscal pressure. Now, intradiscal pressures, how it can be changed naturally. Naturally, if you see this posture, list of postures, okay, so you will be finding that there are certain postures like climbing stairs, 2 at a time, that increases the intradiscal pressure at a very high level. Walking barefoot, that also increases the intradiscal pressure. Now, standing up from a chair, that increases the intradiscal pressure. Excuse me? Any question? Hello?
Okay, there is some, I'm muting all you on.
Hello?
Unmute yourself, Deputy. I muted all, you unmute. Deputy, you unmute yourself.
My audio, okay. So, in those postures where the pain is increasing, okay, so you will be finding whenever in those postures, this is a natural way of increasing the intradiscal pressure. So just ask the patient to do these postures, okay. What actually increases the intradiscal pressure, the pain will be reproduced. Now, even then, it doesn't prove a specific disc is painful because these postures do not differentially increases the pressure in a single disc. Rather, it increases the pressure in all discs. So, we need a way to find out that we selectively can increase the pressure of a single disc. Now, coming to the fact that pain perception is a subjective thing. That means one sensation that may be perceived as a pain to one individual, the same sensation may not be perceived to other person as a pain. Okay, so then the things becomes more complicated. Then how will we compare? Can I say that I have increased the intradiscal pressure to 50 millimeter of mercury or 50 psi? Simple. Okay, then if it causes pain, that means the disc is painful. Can it true for all? Definitely not, as pain is subjective. That means if we found that increasing the intradiscal pressure up to 50 psi, the pain is occurring. For the other individual, the same rise of intradiscal pressure might not be causing pain. So that technique, what we was thinking, that we will be singly injecting dye in a disc and then checking that whether the disc is painful or with a certain pressure the pain produces or not. Whether that is possible or that we can say that this disc is painful, that is also goes wrong because the pain is subjective. Then what is the way? The way is here we need to fix all other parameters except the disc. So how we can do that? We can do that. Suppose we are suspecting that this disc is painful. So what we can do? We can selectively increase the pressure of this disc by injecting the dye, and we will be measuring the pressure inside the disc. And if we compare doing the same procedure in the upper disc, that means the individual is the same, his pain receptors is the same, his all feelings, emotional factors which can modify the pain are the same. But even then, if it is selectively increases pain or even it is selectively causes pain for this disc, but it doesn't causes pain for this disc, then we can say this disc is painful or this disc is sensitized. That is what is provocative discography. So this concept is understood by all? No answer?
Yes, sir.
Okay. So here our target is selectively increasing the pressure of a disc. Okay. So how we can do that? Definitely we need to go for that, but before that we need to know a little bit of the disc anatomy. So here is how the disc is and how the nerve supply of the disc occurs. So disc, the inner part is the nucleus, the outer part is the annulus. And this annulus again divided into three portions arbitrarily: the inner annulus or the inner 1/3, middle 1/3 and outer 1/3. In outer 1/3, we have the blood vessels and the nerves, and these nerves are the derivatives of the greater communicants, the sympathetic chain, and the sinovertebral nerves. Okay. Now they forms a plexus anterior to the posterior longitudinal ligament and posterior to the anterior longitudinal ligament, and they are continuous from lateral side to side and above up downwards. Okay. So due to this distribution, the pain in case of discogenic pain is so diffuse and sometimes changes the side as well. So to find the disc as a pain generator, apart from the discography, the other features what we can get as a pain generator are history, physical examination, and hyperintense zone in the MRI, and sometimes modic type 1 change is also considered as a sign of disc degeneration. Okay, but again, these are objective signs. This do not prove the disc as a pain generator. And in X-ray, if there is intradiscal gas shadow, that also suggests that this disc might be degenerative. And if there is disc height reduction, that can also suggest the disc may be degenerative. Now here we can see a pearly white spot. The arrow has moved a little. Okay, the picture is moved actually. So this arrow should be here. So this pearly white spot, what you are able to see, is actually the hyperintense zone, and it is only visible in the T2 image because in T2 water looks white. So here we can see the CSF is white, but in the posterior annulus you are getting a pearly white small spot, and that is the hyperintense zone, and that also signifies disc degeneration. Okay, so radiographical studies we get is the high intensity zone, The lumbar disc on MRI in the patient with low back pain could be considered as a reliable marker for the painful outer angular disruption. Now, to perform discography, we need an informed consent for the patient, discuss the need for the procedure. The patient participation in the procedure is must because it is a subjective test and patient has to say whether his disc is painful or not. We need to describe the whole process to the patient. Okay, and intravenous antibiotics 30 minutes preoperative. We all know disc is a very sensitive structure. If there is disc infection, it is actually a nightmare for us to treat. So we should give intravenous antibiotics 30 minutes preoperatively, and sedation, if preferable, it is preferable to avoid sedation. Okay, and if you want to give, it should be minimal, or try to do it only with the local anesthetic at the skin and subcutaneous tissue. Now coming to the pre-procedural preparation, needles is required is the introducer with the discography needle. Introducer 20 gauge is given to avoid the skin commensals to enter to the disc. Then we need the syringes, we need the disc monitor, full body drape. So these are the common things what we need for the most of the procedures. Now positioning, patient is supine, put a pillow below the abdomen to reduce the lumbar lordosis and put all the monitors, the fluoroscopy in it. Okay. Now we need to put the needle at the center of the disc. It may not be the exact center, but it should be at least at the nucleus part. Okay, so how to do that? It is similar to the transforaminal what we have shown, but here we need to enter to the inside the disc. So we need to puncture the disc and we need to enter the disc. So in the oblique view, after getting the Scotty dog, we should put the needle, and remember, as it is a comparative procedure comparison between the two discs, we need to do at least at 2 discs. Okay, preferably we should do at three levels, one suspected level, one above, one below. So all 3 levels we should need to put the needle like this. Okay, and remember here all the needles will not be in the same angulation because the discs are not in the same angle. And then we need to inject the dye with the disc monitor. Disc monitor is a very small equipment by which we can increase the intradiscal pressure. Okay, and here it is a like a syringe but with the pressure gauge and a controlled way to increase the pressure. Okay, it is a screw type of thing. So it is screwed from the posterior side and the pressure is seen in the monitor, and the pressure is maintained according to Pascal's theory throughout the system, and the system starts from the discs up to the monitor. So all through the pressure remains the same. So we need to measure 3 important parameters. Okay, 2 parameters we need to observe and 1 parameter we need to derive. So what parameter first is important? At what pressure the pressure inside the system is equal to the resting prone interdiscal pressure. So we need to increase, and at the moment when the interdiscal pressure and the pressure inside the manometer or inside the system is the same, if it slightly crossed, then the fluid will start flowing from the system to the disc and the dye will start entering the disc, and you need to observe disc at the continuous view. You need to okay. Dr. Anand Misra was actually translating in Bengali, I think. So the thing is, we need to equalize those pressures, okay, so that the fluid starts flowing inside the disc. Okay, so and we note that pressure as the opening pressure. It may be 2 psi, 4 psi. So whatever, we need to note that is the opening pressure. So we need to do this procedure under direct fluoroscopy, and we'll check when the dye starts coming inside the disc, and we note the opening pressure. Now, next thing what we need to do, we need to find out the peak pressure. Peak pressure is at which the patient says, my pain is more than 6/10 or 7/10, just 7/10 in a 10-point visual analog score scale. So once it is achieved, then we should stop. We should not go further, and we will note that pressure. Okay. So there might be one condition. Number one, you are increasing the pressure, but the pressure is not increased. Then what is your conclusion? Any idea? You are rotating it, you are increasing that, trying to put the die, but the pressure is not increased. Simple. The disc is punctured. That means the fissure is such, the die is coming to the epidural space, it is communicating with the epidural space. The die is coming to the epidural space. That's why the pressure is not increasing. Or it may reach up to, if up to 90 psi, we should allow to increase. If even there is no pain, we should consider the disc as a normal disc. Okay. So that thing we need to check. And the difference of the peak pressure and the opening pressure is the pain pressure or the pain producing pressure. Now, if the pain producing pressure is less than 15 psi, we should consider it's a chemically sensitive disc. That is almost sure shot evidence. That means the patient is suffering from discogenic pain. Then if it is between 15 to 50 psi, we should consider it as a mechanically sensitive disc. Here we should consider it as that the patient is maybe a case of discogenic pain. And then if there is indeterminate response between the 50 to 90 psi, then we should consider as the intermediate response, and normal if there is no pain in 90 psi. Depending on the results, we should make our diagnosis. We should consider as unequivocal discogenic pain. If stimulation of the target disc produces concordant pain, pain intensity is rated being 7, at least 7 on a 10-point visual analog score scale. Pain is reproduced at a pressure less than 50 psi. That means one chemically sensitive disc and two adjacent normal discs. That's why I have told that here the pain is subjective. So always we need to compare with the normal discs. So if we are getting one chemically sensitive with two adjacent normal discs, then we should consider as unequivocal discogenic pain. We should consider it as a definitive discogenic pain if you are getting one chemically sensitive disc and one normal disc, and other we are not able to do, like L5S1 disc. We cannot go the S1 S2 disc because it is not painful, it is expected, or it is fused. So in those cases we have only achieved one level, that is the L4-5. So we can say that as a definitive discogenic pain. Or if you are getting one mechanically sensitive disc and two adjacent normal control, then we will consider it as a definitive discogenic pain. And we'll be calling it a probable discogenic pain if you are getting one chemically sensitive disc and one control disc that is non-painful. Okay, so in those cases, we should consider it as a probable discogenic pain. Okay. Next, we need to find out the discography patterns. Okay, and here the common patterns what we go is for these patterns. Okay, so what are these patterns? So here, after putting the dye, we have done the CT scan and we are able to achieve this picture. Can you tell us which type of this degeneration is this? Remember, there are 4 types of degenerations. This degeneration where the dye is only in the nucleus, that is no degeneration, grade 0. Okay, so here it is normal disc. Here we are getting total chaotic pattern with multiple fissures. Okay, it is grade 5 or more than grade 4. This is what is grade 4. Okay, then what is grade 2, 3? 1 is when the dye is going only to the inner third of the annulus. 2 is when it is going the middle third of the annulus. 3 when it is going to the outer third of the annulus. 4 when we are getting an additional radial fissure along with the annular fissure. That should be called a grade 4. So this is grade 4 with the 2 radial and 2 annular fissures. Okay. Again, this is grade 4 with a single radial and annular fissure. So that is how we grade the discs. Now coming to the complications. Discitis, which is rare but devastating, as I've already told, needs a long-term IV antibiotic therapy. Otherwise, it is very difficult to treat and manage. There might be chance of nerve root damage, disc rupture, vertebral plate damage, visceral damage if you are doing at the higher level. So these are the complications. And in conclusion, we can say it's a very good way to find out or prove the disc as a pain generator. Damaged disc is not always a painful disc. This can be painful. Discography can reproduce the pain that is because of the disc degeneration. But again, discography is lost its favor because even if you make the diagnosis, our treatment is very limited. Okay. So, and it is a comparatively invasive procedure with a chance of discitis. So nowadays, the discography is not that common as it was used to be in past. So that was all. Now, sir will be showing you the procedure. Hello, Dr. Arnab বিশ্বাস, please mute your microphone.
Okay, so discography procedure, already Devjyoti discussed the basics. So I'll be demonstrating it. But if you can remember the other fluoroscopy guided procedures, you can remember the early steps, basic steps. Basic steps are same. First, patient will be lying prone and they have to take C-arm in AP view. So in the C-arm in the AP view, sometimes spine is rotated. So you have to understand that this is a true AP view. And for that, you need to rotate the little bit right or left. And then you need to make it squaring of the vertebral body. That means perpendicularly, the beam will be falling on the target vertebral body. This is the second step. And then you have to rotate it to make the what? Scottish dog image. So here, little more than the Scottish dog image is what is needed. So first step is true AP. Next step is making the end plate parallel. Third step is oblique to make a Scottish dog view. Here, little more than the Scottish dog view is needed to go. So come here. এগুলো কি করা আছে? একটু উপর থেকে ফোকাস করতে সুবিধা না, বলছি উপর থেকে ফোকাস করো। Okay, so what we are doing first, patient is lying prone and we are having an AP image. So first AP image, picture. সোজা করে দাও। আমি একটু সরিয়েছিলাম। আর একটা শট দাও। Okay, so how to know that it is a true AP image? So the spinous process should be equidistant from the তোমার এটা কোথায়? So the spinous process should be কোনটা? এটা এটা তুমি দেখি দাও, আমি বলি। So spinous process should be equidistant from the two pedicle. So till that you have to rotate it either obliquely on either side to make it true AP. So first is to make a true AP. Then next step is making the end plate parallel. So for that, already it has been discussed in the earlier class that the lower lumbar vertebra you need to make a cranial tilt, and the upper lumbar vertebra we need to make a caudal tilt. Why? Because our spine is curved, lordosis. So lower lumbar face towards this, so your C-arm should be coming like that, and upper lumbar your C-arm should be coming that. That means for the lower lumbar you need to make a cranial tilt. For the upper lumbar you need to caudal tilt. How much? Till you see the end plate parallel. Here already in this level picture, you see at the level of the L34 picture. Okay, so at the level of the L34, that means at this level picture, at this level end plate is parallel. You see, At this level, end plate is parallel, but at the level of the L4-5 picture, L4-5 end plate is not parallel. L5S1 end plate is not parallel. So if you wish to do the procedure in the L4-5 or L5S1, you need to make a cranial tilt, like I'll be doing at the level of the L4-5. So end plate is not parallel there. You see, you can see the double line there. L4 lower end plate, there you can see the two lines. So you need to make it oblique till cranial tilt. That's till that two lines is becoming one line. You see, now it is parallel, end plate is parallel. So these are the basic steps. So for any lumbosacral procedures, these are the steps you need to follow. A true AP view, then make a craniocaudal tilt to make the end plate square. This is called squaring of the vertical body. And then you have to make the ipsilateral oblique. If I am doing the procedure from the right side, I have to make it oblique on the same side, on the right side. Picture. So now you see, now you'll be getting the Scottish dog image. You see, L5 vertebral body, L4 vertebral body. You can imagine the Scottish dog. So here, what is important that I'll be trying to make the facet joint at the middle of the vertebral body. That much of lateral rotation is needed. So you can see this picture. Sorry, picture. So this is the vertebral, this is the supraarticular process, and this is the facet joint picture. So how much should I rotate? The total vertebral body, the facet joint should be coming in the middle. So I need to rotate it more, and gradually the Scottish dog image should be very clear. Picture. I need to rotate it slightly, still slightly more, little bit, few degrees. Best. That's all. So now my facet joint has come at the middle of the vertebral body, and my needle entry point would be just lateral to the superior articular process. Picture. So this is a superior articular process. Picture. This is a superior articular process. So my needle entry point will be just lateral to that. Picture. So this will be my needle entry point, and you need to take a long needle, 12 centimeter, or you can see the needle. 12 centimeter, or at least 12 centimeter, or sometimes 15 centimeter needle is needed. Ordinary spinal needle, it cannot do a discographic procedure. So my needle entry point is here. I'm checking it again before starting. Picture. So that is my needle entry point. Picture again. I can come little more. Yes. So this is my needle entry point, and I'll be making in tunnel vision. I'll be going. Picture. So almost tunnel vision. Picture. Okay, very good tunnel vision. I'll be going in this way till I feel directly. I'll be feeling the disc, or sometimes your needle might be hitting the superior articular process. In that, you just need to rotate it. I'm just hitting the disc, and I'll be going by lateral view now. Lateral view to understand depth. So sometimes we call it as depth, direction, depth. So you have to check lateral view to understand how much your needle tip is traveling. How deep is your needle tip? Okay, you can see my needle is just touching the annulus in the upper part. So I still can manipulate a little bit. I can go in the middle of the disc. Picture. You see, I have manipulated a little bit, came little down, and I'm in the middle part of the disc, and now I'll be going inside the disc. Picture. You see, here this is a, the rubber. That's why it is. Picture. I've gone into the disc. So now lateral view, I can see in that my needle has gone. Now I'll be checking by the AP view and oblique view as well. Picture. AP देखो. You can see in the lateral, in the so you can see in the AP view also, if they made the end plate parallel, and you can see the disc is nicely inside, almost in the center. Normally you should, for the discographic procedure, for the ozone nucleolysis and some other, you need to cross the annulus. Exact center is not needed, but still you can picture. So we are almost in the center. and that is the perfect position to inject the dye to do the discography. So this is how your final needle position should be confirmed by the epi image and also by the lateral image. Right? Any questions from anybody? Hello, all of you must have understood the discography procedure. The basic procedures for the other lumbosacral are same. That means you need to have a true epi image, then you need to have a squaring, and then you need to make a oblique view to see a very good Scottish dog image. As I told you, here little bit more, the oblique rotation to have a very clear Scottish dog image is important. And to do that, you need to keep the facet joint in the middle of the vertebral body. That is your endpoint. And then you choose a needle entry point just lateral to the middle of the disc, lateral to the superior articular process. Go by the tunnel vision, hit the annulus, and then by the lateral view, you advance further to go into the middle of the disc. Somebody is asking about the interdiscal pressure monitoring. Interdiscal pressure monitoring is very difficult. For that, you need some instrument called the disc monitor. Actually, disc monitor ache? Okay, just we are having the disc monitor. I'm just trying to show you where it is. Otherwise, next day I'll be showing you. The disc monitor is a costly instrument, that is one time disposable one. There is a battery there. There is a monitor. When you are attaching it and you are pressing the dye inside, that that pressure will be showing you the how much PSI pressure, pound per square inch pressure is there, and how much dye you have injected inside. So that will be coming into the disc monitor. Disc monitor is a disposable, and you can where the facilities of injecting the dye is there. If it is available here right now, I will be showing you. Otherwise, next day we can show you. But ordinary injection of the disc dye is not enough to measure the pressure. To measure the pressure, you have to attach some pressure measuring instrument, and that will show you what is the interdiscal pressure. Opening pressure means, how a liquid will flow from high pressure to low pressure, isn't it? So your needle is there inside the disc. You are injecting it. Injecting means you are pushing the piston. You are pushing the piston. That means pressure inside your syringe in the fluid is increasing, right? So in which direction the dye will flow? If the interdiscal pressure is very high, you cannot inject it until your syringe pressure will go above the interdiscal pressure. So the point when your dye starts appearing inside the disc means your syringe pressure is just above your disc pressure. So this is called opening pressure. Opening pressure means the pressure when the dye start first appearing inside the disc. So that is the pressure inside the disc. That means when somebody is lying prone or supine, interdiscal pressure is not zero. Some opening pressure will be always there. Why? Because our spine is not a straight line, it is curved. So there will be some pressure inside the disc, even if the patient is lying down prone or supine. So you need to apply some pressure to go above that pressure, and then only your dye will be appearing. So this pressure is opening pressure. That means opening pressure means, in other words, opening pressure means it is the normal pressure when the patient is lying down in prone position. That is your opening pressure. Is it clear what is opening pressure?
Excuse me, sir.
Yes.
If I have a suspicion that more than one disc is pain generator, then how many needle I have to insert it for that discography?
For each disc, one needle. Suppose you are thinking that, okay, one very important issue what Dr. Devjyoti has told, that you must be having a normal disc where raising the pressure more than 90 psi is not going to generate any pain. That is taken as a control. So if all of your discs are generating pressure, what is the meaning of that? So then your validity of your test is not there. So that means patient might be having the the central pain, central sensitization. All these are possibilities. So at least one disc raising the pressure above 90 psi should not produce any pain. That is taken as control. And then other disc, whatever he has told, that above the 15 psi, above the 50 psi. So in that way, you have to understand how many discs are painful. But as he already mentioned at the end, he has mentioned that discography is an invasive procedure. We are not generally doing it. We are, because discography is not a curative procedure, treatment procedure. So we always try to avoid poking in the disc as much as possible. Some literature says that the disc should be respected as temple. It should be respected and it should not be going inside unless it is very much needed. So discography is nowadays very rarely done, but the concept, it should be very clear. And discography is done mostly when you are doing some ozone nucleolysis procedure, or ozone nucleolysis is basically nothing but same discography. Here, instead of dye, instead of giving any other drug, you are giving ozone. First you are giving dye and then you are giving ozone. So that is your ozone nucleolysis. When you're doing that, you can do that discography. When you are doing an endoscopic discectomy, you can do that. That means when you are adding some therapeutic procedure, you can add discography also. But only discography for diagnostic purpose is very rarely done. Earlier, 5 years back, we used to do a lot in Darodia also. We have old discography machines, instruments also. But nowadays, we do not do the discography unless we are adding it with some therapeutic procedure like ozone nucleolysis or endoscopic discectomy or something like that.
Okay, thank you, sir.
Okay, so if no more questions are there, can we end today's session? Chance of root injury is always there. Okay, this is not a question. Okay, fine. It's in my answer. Right. Chance of disc root injury is there because we have seen the transforaminal epidural is done for the same approach, almost same approach. Lateral to the supraarticular process, Campion's triangle, you are going that. So nerve root is very close. So if your little bit above or below, then there is a chance of hitting the nerve root. And that is the reason why discography must be done in awake patient. If you're touching the nerve root, patient will simply kick you, will not allow to injure the nerve. That is the reason why you must do it in awake patient. Opening pressure, just now I told, opening pressure is the pressure in the manometer when the dye first appears inside the disc. So there you are putting the needle, you are attaching with a disc monitor and you are injecting it. When you are injecting the dye, you can measure the pressure at which pressure you are injecting the dye. And you go on looking at the monitor to see when the dye is first appearing. As soon as the dye is appearing on the disc, on the monitor, you look at the pressure, at which pressure you are injecting the dye inside. That pressure is your opening pressure. That means that pressure is your normal pressure when the patient is lying down in prone position. Any book from where we can practice the multiple choice question? We are having the best multiple choice question by Chinmoy, from Indian origin. So read that book. Multiple choice question in pain medicine. It's available in Amazon. It is available in Amazon. You can go there and see it and order it from there. So for Kahoot exam, whatever materials we are providing you, that is enough for answering these questions. Not only for the Kahoot, but also for the final exam. Okay, if no more questions, so for today, let us tell good night. Okay. Please, for the last time, open your microphone and say yes. Good night.
Thank you, sir. Good night, sir.
Good night.
Good night, sir.
Good night, sir. Thank you, sir.
Good night, sir.
Good night, sir.
Oh, wow.
Thank you, sir.
Nice,
Good night,
sir.
sir.
Thank you very much.
Thank you, sir.
Goodbye.